Good evening, fellow colleagues and all participants. I am Dr. Rizin Kusop, the Secretary of APS. Welcome to our free live streaming webinar brought to you by Association of Private Practitioners Sabah, APS. If you have questions, please write them down on the comment section in the YouTube platform and they will be addressed by the speaker at the end of the session. Our speaker for this evening is Dr. Terrence Soong. Dr. Terrence Soong Kwong Meng is the founder and medical director of Eyemedics Specialist Eye Centre in Kota Kinabalu. The exact address of his practice and the contact numbers are available on the posters given to you earlier in the WhatsApp group. He is a senior consultant ophthalmic surgeon and retinal specialist. He obtained his medical degree from the University of Manchester, UK, and has trained and worked with the UK National Health Service for many years. He underwent a subspecialty fellowship in vitreoretinal surgery and retinal disorder in Adelaide, Australia. In Malaysia, he practiced as a specialist at the University Malaya Medical Centre and at Selayang Hospital in Selangor. He is also currently the treasurer of APS. The topic for this evening is common eye problems in primary care. Ladies and gentlemen, Dr. Terrence Soong.
Thank you, Dr. Rizin, for the kind introduction. Welcome, everyone. Thank you for taking your evening to spend some time for me to just go through some of this common topic that most of you may have some questions about. Okay, so let's not delay. Today, I'll be talking about the common eye problems in primary care. Of course, there's plenty of eye conditions that presents to a primary practice. However, I will try to break down to the most common and eye problems that actually present to you to most of you. Now, first and foremost, I would like to thank our sponsors for this talk, such as Canon Medical, Path Lab, Medinix Diagnostic Care, and also specifically for the eye, Alcon and Santen. Now, I don't have any financial interest of any of the products or techniques presented in this talk. Now, let's go through a few common eye symptoms. Most notably, I would think that most GPs will actually have their patients coming in complaining of red eyes. Sometimes they can start complaining of itchiness, foreign body sensation in the eye discharge, blurring of vision, and also pain, either individually or in combination of any of these symptoms. Now, when a patient presents to you with an eye problem, history is quite important to get the key diagnosis. This is because the eye has, despite being a small organ in the body, a good history can actually pinpoint the likely cause of the disease. So, we would advise particularly to ask for whether there's any history of trauma, any previous ocular eye history and medications, such as previous operations, any recent or current contact lens wear, but also consider the systemic conditions that the patient has, especially conditions like diabetes and hypertension. So what do you need in a general practice? We would recommend to keep some of this equipment if you do not have it already. A visual acuity chart, such as the Snellen chart, you don't actually need a wall-mounted Snellen chart, as now with modern times you can actually have a Snellen chart on your smartphone. There are many apps that actually will be able to give you a Snellen chart which can actually measure the visual acuity quite accurately. Pen torch, it doesn't have to be the specific eye pen torch. You can actually get a simple bright pen torch, whether it's LED or your common bulb torch. A cotton bud, simple cotton bud, iPads, micro pore tape. You might have to dust off your direct ophthalmoscope from your old houseman or your medical school bags. Okay, a magnifying glass or simple magnifying loops. This is to be able to visualize the anterior structures of the eye. I've looked through the internet, and you can actually get quite nice looking loops through Shopee or Lazada, and they actually work quite well. The most GP practices may or may not store some local topical anesthetic drops, eye drops, such as amitocaine or lignocaine. The anesthetic eye drops should be, if you are planning to use it to examine the eye, best is to get an topical eye anesthetic drop. You should not use the regular anesthetic eye drops, because those are of higher concentration, and it will really sting the eye if instilled onto the patient. Now, medication-wise, apart from the local anesthetic, which I've just mentioned, it might be worthwhile having stock of some fluorescein strips. They come in. Again, you can actually buy it from a proper distributor, or even through your Shopee or Lazada. They do have boxes. They do sell boxes of these fluorescein strips, which comes in 50 or 100. And if you're in a group practice, you can actually distribute them together. They are all actually sealed in single sterile packs, which can be torn and used and disposed. Topical antibiotic, such as ciprofloxacin eye drops, chloramphenicol eye drops, that will be sufficient. Topical antiviral, such as acyclovir eye ointment. These are actually more costly, and there are actually two preparations for antiviral eye ointments. For ointments, one is for the skin and the other is for the eye. So if you're planning to prescribe it for the eye, please make sure that you get the eye preparation instead of the topical skin preparation, because that is of a higher concentration and should not be used on the eye. Now, simple ocular lubricants, such as Tears Naturel, and a very common and easily available ocular lubricant or tear supplements, such as the Alcon Systane range of eye drops, as shown as in the picture here. Now, some may argue if you should also stock topical eye steroids. I would feel that topical steroids should be used on the advice, or at least consulting your ophthalmologist before prescribing it to the patient, because of its possible adverse events if not monitored properly. Now let's go to the common eye condition, which is conjunctivitis. I mean, the symptoms as probably, if not a weekly affair that that a GP actually encounters, is a red discharging eye. With the actual symptoms, you can roughly tell whether the conjunctivitis is bacterial, viral, or allergic. The bacterial conjunctivitis will be mucopurulent, especially in the morning, with the eyelids all stuck down, with yellowy green discharge. Now, for a viral, it can be purulent as well, but it will be more on the watery discharge rather than the thick mucopurulent discharge. As for the allergic conjunctivitis, you will get the patient complaining of it being itchy and also with some mucoid discharge. Now, it can be associated with some blurring of vision if it has affected the cornea. Now, the signs is, of course, a red eye, but take in note in particular the bulbar conjunctiva, which is at the sclera, it's all injected, but also the tarsal conjunctiva, which is at the inside of the lid if you just pull the lid. So a conjunctivitis is usually, it will affect both the bulbar and the tarsal conjunctiva. Now, treatment is simple. I mean, you can start it with. Now, as an introduction, if you plan to use a fluorescein strip, one should actually use a topical anesthetic before using the fluorescein strip to try to stain the eye, because fluorescein itself stings. So you can use it just to look for any associated corneal ulcer with the conjunctivitis. Now, treatment is with topical antibiotics, whether with chloramphenicol or with your gentamicin or your siloxane, ciprofloxacin eye drops. Advise the patient good hand and eye toileting. That means they should, whenever there's mucopurulent discharge, they should start cleaning the eyes with a clean tissue or a clean towel. Advise them not to share towels, or even if they are sleeping, sharing a bed with someone else, please make sure that they do not interchange the blankets and even the pillowcases, because that can transmit the conjunctivitis to the next person or to the other eye. If the patient complains of grittiness, you can actually prescribe them with some topical lubricants such as tears, artificial tears, or even the cysteine, just to get them feeling comfortable. Now, if you suspect that the patient has allergic conjunctivitis, then you can actually prescribe topical antihistamine plus or minus mast cell stabilizers such as Patanol, eye drops, or even Pataday. And those with associated rhinitis, sometimes what I would do is I would actually prescribe some oral antihistamines as well. Now, this is quite a common condition, especially during this MCO, where there is a lot of screen time being used. Now, dry eyes or exposure keratopathy can be caused by a few can be caused by a few reasons. Now, it's either the eyes do not make enough tears, or the tears that you have is sufficient but evaporates too quickly. Usually this is called tear film instability. So just because someone has dry eyes, it doesn't mean that they do not have enough tears. Now, of course, if you get older, especially the postmenopausal women, this condition becomes a bit more common. Now, it can also affect patients who has other connective tissue disorders and can be associated with other conditions such as blepharitis and contact lens wear. So what are the symptoms? Patients will feel gritty, dry, they will feel a sandy discomfort, almost like sand in the eye. Now, if the cornea is greatly affected, they will complain of blurred vision and photophobia. Now, usually this condition is bilateral. It doesn't have to be symmetrical. One eye can be worse than the other. So, as with conjunctivitis, you can have redness in the eye, but this is more circumscribed towards the edge of the cornea. And if you stain it with fluorescein and topical anesthetic, you will see this punctate erosion, this yellowish punctate erosion upon shining with a blue light. So, what are the treatments of, how can you treat dry eyes and exposure keratopathy? Start them on some tear substitute, as we can see with the with artificial tears, and you can add some eye ointment that can be used at night before they sleep. The reason why we prescribe eye ointment at night, because usually eye ointment or gel can temporarily blur the vision. So patients might not like to use it during the day, as it will blur the vision for the next 5 to 10 minutes. So we will usually prescribe a tear substitute, a simple eye drops such as Systane or artificial tears during the day, to be used about at least 4 to 6 times a day, depending on the severity, and an eye ointment before they go to bed. Now, what's blepharitis? Now, the word blepharitis means swelling, inflammation of the lid margins. So, patients can present with, again, a gritty and sore eye. You can see, if you observe properly, you can actually see crusting or even dandruff-like debris on the eyelashes. With an injected eye, close to the margin and around the bulbar conjunctiva, as in the diagram. Now, it can be associated with bacterial infection, the conjunctivitis, which is recurrent. That means the patient presents to you, you have treated the conjunctivitis, but within a month, they will come back with a repeat infection. So, you have to suspect that that person might have blepharitis, an underlying blepharitis, which is constantly collecting dust, dirt, or pathogens such as bacteria or viruses around the lid margins. So patients will also come with crusting in the corners of the eye in the morning. If you actually look in the microscope, we can actually see the meibomian glands, which are the oily glands at the lid margins at the base of the hair, the eyelash follicles. They actually have overproduction of the sebum, and this is how the debris and the bacteria collects on the base of the lashes. Now, again, you can instill some topical anesthetic and fluorescein to look if there is any involvement of the cornea. Now, how do you actually advise the patient to treat this condition? Get them to perform what we call lid hygiene. So the underlying problem is the inflammation and the collection of oil and crusting and debris along the lid lashes and the margin. So get them to actually, you can actually get a clean gallipot or a clean bowl, add some boiled water which has been cooled down to warm, add a few drops of baby shampoo. The reason why we use baby shampoo, so that if some of the solution inadvertently enters gets in contact with the eyeball, it doesn't sting as much as the adult shampoo. Get them to clean the lids by using either a lid wipe. You can actually get one of those square facial wipes, or even a cotton bud, where you pull your lid down and you start scrubbing the base of the eyelash at least twice a day for the first month. Now, we would encourage the patient to also do some warm compresses on the lids. The reason for doing that is to actually soften any crusted oil collection, open the pores of the lid margins to encourage the excess oil, so that when performing the lid hygiene, you can actually easily remove. It's almost like a lid facial. So you kind of clean, get the oil and the sebum and the secretions out, so that you can clean all this excess oil away. Now, we would actually, for an active blepharitis, we would encourage the prescription of a course of antibiotic eye ointment, such as fusitamig, twice a day for 2 weeks, applied in and also at the lid margins. Now, this is styes or chalazions. Patients can present with a swelling, sometimes painless or painful lid swelling on the upper or lower lid. Patients can come with an associated conjunctivitis with discharge, watery, and a red eye. So the signs are actually quite a round, circumscribed swelling, as shown as in a picture. It can be associated with surrounding cellulitis. Now you have to actually observe this, especially for the younger patients, especially in children, because the orbital septum is not as developed as an adult patient. So any infected stye or skin infection can spread quite rapidly and quite severely. So what can we do for someone who's got a regular chalazion, which is not complicated with a preseptal or orbital cellulitis? Again, we advocate for warm compresses. Okay, this is to open up the meibomian gland pore, as to encourage the pus within, or the collection within the chalazion, to discharge its contents. Prescribe a course of antibiotic eye drops or ointment for about 1 or 2 weeks, such as chloramphenicol or even fusitamig. Now, if you suspect there is early cellulitis, then give them some oral antibiotics. Now, usually the need for incision, any surgical drainage, it's either if it persists after a month, or if the patient has requested for it to be incised due to its chronicity or cosmetic reasons. So if that's the case, that usually needs to be referred to your local ophthalmologist. Now, corneal abrasion is another condition that can commonly present to your clinic. Now, the symptoms are actually quite dramatic. Patients will complain of very sharp, severe pain, as if someone is taking a hot needle and poking or scratching the eye. Patients will actually come with a foreign body sensation, that the eyes will be watering, and they will be very, very sensitive to light. Now, if the abrasion is really severe, you can actually see it without any staining. And of course, the patient's eye will be injected. Now, what if you see such patient, it will be good to stain, actually to see the severity of the abrasion. Now, if you do see a linear abrasion as the picture previously, there is some linear lines across the cornea that will usually show that there is, the patient blinks, there's actually something abrading the cornea as they blink. So that will suggest that there might be a subtassel foreign body on the upper lid. Now try to evert the upper lid to exclude a foreign body. Now patients who come complaining of redness and painful eye, watch out for a distorted pupil, because the history might not actually be related to a possible more serious condition such as a penetrating eye injury. So if you actually see a distorted pupil, you need to refer to an ophthalmologist to exclude the penetrating eye injury by a foreign body. Now, if it's a simple corneal abrasion and you have removed or excluded a foreign body, a course of topical antibiotic again for a week. Now, patients might feel more comfortable if you pat the eye. So you can get them to pat the eye during the doses of the topical antibiotic, and if it's severe, and if they need analgesia, we would actually, and there is no contraindication, an oral non-steroidal might be the preferred analgesia for such patients. Now, for a corneal foreign body, you might actually see something visibly on the cornea. Patient, yes, will complain of a foreign body in the eye. The eyes will be watery and there will be pain similar to a corneal abrasion. Now, it's good to actually ask the history of how the patient has come to have this eye condition. Beware of what we call high velocity injury, such as a hammer and chisel injury. Because with such an injury, they might have a dual foreign body, one on the exterior and one internally, especially for a metallic foreign body. If there is a metallic foreign body that has penetrated within the eye, that will need surgical removal rather urgently. Now, what are the signs? You can actually sometimes see a opaque corneal foreign body in the eye, and the the patient will have a localized redness within the eye. Now, again, you can examine with topical anesthetic and fluorescein. Now, we would encourage you to do that because some corneal foreign body are not as visible as the picture, like a metallic superficial foreign body which has a rust as the picture shown. Sometimes it could be a broken piece of a contact lens or a clear plastic which is not clearly visible. So by instilling topical anesthetic and fluorescein, you can actually see a margin of the foreign body that does not take the stain. Now, you can try removing the corneal foreign body initially with a cotton bud. If you find that it is difficult or embedded slightly, you can try to remove it with a needle, but I would say that if you are planning to try to bend the tip of the needle as such that you are gently scraping the superficial of the cornea, so that is you minimize the risk of actually penetrating the eye with your needle. So you can try to use the smallest gauge needle. Okay, you can actually mount it on a 3 or a 1 mil syringe. Okay, you can bend the tip as such with your forceps. Okay, and at the needle, try to bend the tip bevel in rather than bevel out to reduce the chance of you actually penetrating the cornea. Now, once you have confidently removed the foreign body, again, with any abrasion or epithelial defect or any injury to the corneal, prescribe them a course of antibiotic, eye drops, or ointment. The reason why eye ointment is usually recommended because with the eye ointment, the corneal defect is actually nicely coated and the patient might actually feel more comfortable with an eye ointment rather than an eye drop. Again, ocular lubricants such as the artificial tears or Systane and oral analgesia for the patient's comfort. Now, as before, a subtassel foreign body is a foreign body which is stuck at the top of the upper lid. The patient will localize the foreign body sensation on top of the lid, and if it has abraded the cornea, they will have the conditions of a corneal abrasion such as redness, watery, pain, and photophobia. So, as before, how do you try to look for it? Add some topical anesthetic and fluorescein to look for corneal staining. Now, this is a video which I have made to try to show how you evert the upper lid to try to exclude a subtassel foreign body, and if you see a foreign body, you can try to remove it with a cotton bud. Now, you can either use a cotton bud or a paper clip. Try to lean it on the skin crease on top of the patient's upper lid while getting the patient to look down. Then with the other hand and your fingers, try to grab some of the eyelashes and flip it over to flip the upper lid inside out. Now this is a short video. You can just have a look. Okay. I'll just show it again. put the cotton bud or a paper clip on the skin crease, grab the eyelashes, and while patient is looking down, and look at the subtassels. Now, as mentioned before, the subtassel foreign body is usually associated with a corneal abrasion. So again, a topical antibiotic eye drop or eye ointment for a week, oral analgesia, and some ocular lubricants. Now, patients can come with sudden onset of redness within the eye, and usually it's painless. They might have a foreign body sensation as the picture shown. This is a subconjunctival hemorrhage. It is a bright red hemorrhage within the conjunctiva, and patients usually don't realize it on the actual day, or their friends or relatives might actually mention it to them of their red eyes to get the eye checked. Now, again, such patients who presents to your clinic, you should get a good history to try to exclude any trauma, because a subconjunctival hemorrhage might actually mask a penetrating eye injury or something more serious. As the picture here, you can see that there is prolapsed uveal tissue and iris from a scleral rupture. Now, if someone presents with a regular subconjunctival hemorrhage, it's actually good to check the blood pressure, check for any history of what we call Valsalva maneuver, such as coughing, straining, any trauma to the chest, or some severe vomiting. Now, if the patient is on regular use of non-steroidals or any anticoagulants, such as aspirin or warfarin, you might consider checking to make sure that their coagulation status are within the required limits. Now, mild to moderate subconjunctival hemorrhages do not need any treatment. You just need to reassure the patient that this condition will resolve within it. There will be improvement within a week or two, and it should resolve completely at least before a month. Discourage them from rubbing the eye, because a subconjunctival hemorrhage is just like any bruise. If you get a bruise, rubbing it or massaging it will actually delay the healing. Now, recurrent subconjunctival hemorrhages may require further investigation to exclude any underlying clotting disorders. Now, episcleritis is a condition where the patient will actually complain of some soreness within a sector of the eye, whether it's usually temporally or nasally, might be slightly tender. Patient might complain of a burning sensation with a localized redness. Now, once examined, you might actually see it slightly raised, as if there's a little yellow blister prolapsing from the eye. Now, again, we can instill some topical anesthetic and fluorescein to look for any corneal staining, because if the episcleritis is associated with a keratitis which affects the cornea, it will stain the cornea, and the pathology the underlying pathology will be slightly different from a self-limiting episcleritis. Now, if you do not have any eye drops, you can actually prescribe them with oral anti-inflammatories such as ibuprofen. This may help with the discomfort, and just some regular ocular lubricants. Now, most of this should resolve within 2 weeks. However, if it doesn't resolve in a fortnight or is associated with visual disturbance or blurring of vision, then they should actually be referred to your ophthalmologist. Now, this is just a little diagram which is quite useful for for common eye conditions that can present to your clinic, which can be divided as painful and painless, and what to watch for according to their signs and symptoms. If anyone is interested, I can actually post this up on the group, where, if possible, you all can print it out and maybe put it in your clinic. So it will tell you, it can actually guide you to the probable diagnosis or provisional diagnosis, and you would know whether you can manage this in your clinic or refer them to your ophthalmologist. Now, this is another slide about acute visual loss, where patients come into your clinic saying that, I've suddenly lost my vision. Now, with a good history, you may be able to tell what are the possible diagnoses, but most of this would require an urgent ophthalmology referral, examination and referral. So it can range from a neurological problem such as stroke or hemorrhage fugax, or actually the visual loss can originate from within the eye itself, such as a vaso-occlusive disorder within the eye, such as an artery or vein, retinal vein occlusion, the optic nerve itself, such as optic neuritis or ischemic optic neuropathy, or a retinal detachment. All these are warrants an urgent ophthalmology referral. Now, just something that I've just added, because we have been getting quite a few patients that come in asking and also presenting at this time where we are actually facing a pandemic, and also many patients and people are getting vaccinated. They can present with related eye disorder due to the actual infection or the vaccine itself. So what COVID-19 or its vaccine can be, they can induce any inflammation in the eye. So in the anterior segment, they can present with conjunctivitis, episcleritis, or even keratitis, which is the inflammation of the cornea. So taking a good history should include whether they have had recent COVID-19 infection or has recently had their vaccines. Now, it can also affect, there are reports saying that it also can affect the posterior segment, such as a serious choroidal central retinopathy. It can affect the optic nerve and the blood vessels, the retinal blood vessels within the eye. This can all cause blurred vision, and you should actually consult and refer to an ophthalmologist if any of this occurs. Now, for those severe, they might actually get ophthalmoplegia where the vaccine or the virus induces an inflammatory response that can actually affect the extraocular muscles and the nerves. Now, it is postulated that how the vaccines can cause this inflammation. It's an antibody-dependent enhancement of pre-existing inflammatory eye disease. So it's also good to take a history to find out if they had all these previous conditions, because the vaccine might actually trigger or trigger the condition again. What we would recommend is, if you actually encounter such cases that does not resolve with your regular treatment within a week, it's worthwhile referring them to your ophthalmologist. However, if any of these conditions present with visual disturbance, then you should actually refer straight to the ophthalmologist, because the inflammation can affect any part of the eye, and with appropriate treatment, we can actually reduce the comorbidities and the damage that is caused by the inflammatory response. So in conclusion, take a good history, because that can help you locate the location and the cause of the symptoms. Recognize the sight and life-threatening eye conditions. For any foreign body or chemical injury to the eye, simple first aid such as copious irrigation with sterile water or normal saline will definitely help the prognosis of your treatment. Don't forget your simple pen torch. Even if you have your smartphone, which has a good light source, that can really help in your clinic. Your ophthalmoscope, dust it from your old case or your cupboard. Get new batteries and start using them. Okay. Don't forget to palpate the eye, because that can help in the diagnosis, in some diagnosis, such as acute glaucoma. And if you're not sure, feel free to just speak to your local eye specialist. I'm sure they will be more than willing to advise you or to guide you on how to treat and manage the patient. Now, a special thanks to Alcon and Santan and all the other sponsors, as mentioned, for sponsoring this talk. Thank you.
Thank you, Dr. Terrence, for that very informative presentation. Dr. Terrence now will address the question in the YouTube chat platform. At the moment, there are no questions yet, but we'll give them some time to start typing and posting their question. I will start with one question. I might have missed it, but could you explain a little bit about this arch welding eye injury? I think it's called also as photokeratitis.
Yeah.
Thank you, Dr. Terrence.
Okay. The arc eye, they call it the arc eye. It's usually caused by the extreme brightness and the luminosity of those patients who actually welds without any protective eye gear, or especially eyeglasses, because the actual luminance of the intensity of the light is such that it actually damages the corneal epithelium, and the patients do not actually realize on the at the time of the the so-called injury. They will realize it after a few minutes or a few hours after actually performing the task, and that's where they will get the arc eyes, where it is actually quite similar. The symptoms are quite similar to exposure keratopathy, where you have a lot of erosions on the cornea with limbal injection. Treatment, uh, as it is as for most corneal conditions, are topical antibiotics, topical lubricants such as artificial tears, and analgesics and oral analgesia. You may actually pat the eye, and of course, if possible, advise them to wear protective eye gear in the future, because you don't want them to come every month having this condition. Okay, to ease their pain, they might benefit from cold compressors. That means get them to get a clean cloth or an ice pack to put over their eyes, and that will ease the discomfort.
Again, thank you, Dr. Terrence. We don't have question from the online participants. I think maybe because your presentation was very clear, which is good. And thank you for all those people who have participated in this online live streaming webinar. Please scan the QR code now for your CPD point. It will be shown in the YouTube channel for about 15 minutes. Or otherwise, can register your name at the link given earlier in the chat group. Thank you to our Secretariat, Ms. Melissa and Adrian, for their assistance. And thank you to all sponsors, Canon Medical, PetLab, Centon, Diagnostic Care, Medinix, System, and Alcon. We will see you again in 3 weeks' time. Thank you.